Okay, welcome everyone again, and welcome to the medical series. Just a few rules before we get started. We'd like everyone to mute their audio and stop their video. This makes for a better playback and a better presentation. We don't hear the barking dogs in the background or anybody moving around. I know none of us have that problem, but it's always the neighbor who has the barking dog. So if you could mute yourself. During the presentation, if you have a question, please type it either into the chat window or you could raise your Zoom hand. The Zoom hand is either in the participants list down at the bottom if you're running with a slightly older version of Zoom, or it's on the main Zoom control bar under reactions. There's a button that says raise hand. It's not the clapping hands, but there's a raise hands button. So if you do either of those, we'll find an appropriate time to break and you could ask your question.
Could the iPhone guest person please mute your audio?
Lady Gaga stunning in a custom Schiaparelli couture gown with a symbolic dove with peach.
Just getting set up here, and we'll go ahead and begin now. So welcome everyone to the OLLI Medical Series. This is a weekly set of lectures every Wednesday, either morning or evening, where we try to bring in doctors from the community to give you information that's geared more towards the retired population. Tonight we have Dr. Shibitz, who's going to be giving a talk on living pain-free in your golden years. Dr. Shibitz is an assistant clinical professor in the Department of Anesthesiology and Pain Medicine. He is a board-certified UCI anesthesiologist and pain management physician who specializes in interventional pain management. He was awarded a PhD in pharmacology from Vanderbilt University in 2009 and his MD from Michigan State University College of Human Medicine in 2012. This lecture will provide attendees with a comprehensive review of the resources available to live a more pain-free life in their golden years. Okay, Dr. Shibitz, if you'd like to take over, I'll stop sharing my screen.
Okay. Well, thank you very much, Bill, for that wonderful introduction. I truly appreciate it. And I absolutely appreciate the opportunity to come and speak with you guys tonight. I am going to share my screen at this point in time. And go into meeting mode. All right. Bill, did my screen come up with the computer presentation share at this point?
Yes, it did.
Excellent. All right. So this is actually one of my favorite lectures to give. It's entitled Living Pain-Free in Your Golden Years. And basically, it's an overview of all the different things that can be done to help you out live a more complete, holistic, and pain-free life in your later years. Before I start tonight, I do have to let everybody know that I am a consultant for Cadenwood Brands LLC out of Newport Beach, but there should be no issues of conflict of interest within this discussion for everybody. So the golden years. It's usually a period in life when you kick back, relax, and enjoy life. Unfortunately for many senior citizens, these years are also filled with various types of pain complaints, which is the absolute basis for today's talk. So, as a discussion overview, I'd like to do the following. First, I'd like to discuss how the US population is aging. I will then go over common causes of chronic pain in the geriatric population. I'll then touch upon nutrition, inflammation, and their role in pain, as well as the potential for pain management. I am a big exerciser. I have been my entire life, and I think it's really important to go over as well why exercise and physical therapy helps keep a body in motion. I'll then discuss a few other adjunct modalities that can help out with pain control, which include massage and acupuncture. I'll then talk about my firm belief in what I consider to be the biopsychosocial model, where mindfulness, meditation, and talk therapy can also help out with chronic pain management. Finally, the last two topics are near and dear to my heart as an interventional pain management specialist. I'll talk a little bit about the pharmacological interventions for pain relief, as well as interventional pain techniques that can help people live a more full, pain-free life. So as I had first alluded to, the United States population is an aging population. By 2035, there will be over 78 million people aged 65 years and older living in the United States. It's interesting to highlight this point because this age group will rise to nearly 24% of the entire US population by 2035. This age group also consumes approximately 36% of total US personal healthcare expenses, and the prevalence and incidence of certain pain syndromes can increase over time. So not only is it a burden on the patient, but it's also potentially a financial burden more on the macro level to the population as a whole. So understanding these issues and treating them appropriately not only does the patient better, but also can potentially contribute to the overall stability of the financial markets here in the United States. So as patients age, the incidence and prevalence of certain pain syndromes also increase. That's why it's important to understand pain as it applies to our geriatric population. Chronic pain or chronic geriatric pain is described as an unpleasant sensory and emotional experience associated with actual or potential damage for greater than 3 months. The prevalence of persistent pain increases with age, and increases in joint pain as well as neuralgias or neuropathic forms of pain are pretty common in the elderly. So what are some common types of pain in this population? As I've put down on this slide, there are basically 2 different types of pain, but 4 different illustrated examples. The main types of pain and its classification can be based on either inflammatory pain versus neuropathic pain. Inflammatory pain is your typical aches and pains. That's your major joint pain, knee pain, hip pain, low back pain, neck pain. Those types of issues where inflammation and arthritis have taken hold of the patient, resulting in that chronic, dull, achy sensation that most people experience. On the flip side, neuropathic pain is more of that burning electrical-like pain. It can take the forms of something like lumbar radiculopathy, where you have an impingement of a nerve resulting in pain, numbness and tingling, and potentially weakness radiating down a lower extremity or an upper extremity, or something like postherpetic neuralgia, which unfortunately is an adverse sequelae of something like the shingles infection. So these are the 2 types of pains that we're mostly dealing with in the geriatric population. I think now that we've discussed and defined what pain is in the different classifications that exist, let's talk about managing pain. So there are many different ways that pain can be managed in the geriatric population. Things as simple as diet can be incorporated or changed to help with inflammation, as well as other chronic pain states. As I had said earlier, a body in motion stays in motion. That is my hallmark to anybody in any age group whatsoever, but especially in the geriatric population. Things like exercise, physical therapy, light aerobic activity and mindfulness, such as activities like Tai Chi, can be significant in their ability to help people out with chronic pain states. Moreover, massage therapy and acupuncture can be wonderful adjunct therapies for myofascial pain and muscular pain. Another really important thing in the treatment of chronic pain states is what I consider to be the mind-body connectedness issue. I subscribe to the theory of thought called the biopsychosocial model, and briefly that means the physical pain can beget mental pain, and mental pain can also beget physical pain, and unfortunately lead into this vicious feed-forward cycle. So that's why it's really important when people have been dealing with chronic pain states, and especially what we call things like centralized pain states, that they undergo certain aspects of talk and behavioral therapy that include mindfulness, meditation, and other forms of CBT. Chronic pain can also be treated with different medications, and we'll touch a little bit about that. And then finally, as an interventionalist, again, I would be amiss of having a talk without talking about different targeted interventional therapies that can help out with managing chronic pain. Let's take a more close look now at these specific management topics. And the first one to start out with is diets to help out with chronic pain. So food elimination has been suggested as an effective and inexpensive therapeutic strategy in patients with migraine headache, as well as irritable bowel syndrome. And basically the whole thought and premise of this is to eliminate allergens in food that can potentially produce inflammation, as well as a host of other reactions that eventually lead to, unfortunately, pain. Another thing that's really important about an anti-inflammatory diet is a diet that is rich in antioxidants, which provides balanced amounts of things like omega-3 and omega-6 fatty acids, can be ideal in helping out with inflammation. One of the big things that I always tell people about is that an ideal diet is a plant-based diet and has a low glycemic index, which is also full of fruits, vegetable, and fish. I think a couple other things that could be incorporated into the diet to help out with an anti-inflammatory approach are things like certain nutrients, vitamins, minerals, as well as fiber. And to expound upon that a little bit more, we have all heard about the Mediterranean diet, as well as potentially people that have gone on a strict vegan diet. These types of diets can also reduce the risk of inflammation, as well as potentially pain as time goes on. One thing that I wanted to point out as my talk goes on is that all my references are available at the end of this talk on a certain slide, and they can all correlate back to the superscript that's seen on my slides as well too. One of the diets that I love highlighting is the elimination diet. And a gentleman by the name of Dr. Wheel came up with this anti-inflammatory food pyramid. And we've all heard about the food pyramid. It was developed, back in the 50s and 60s. The difference between this food pyramid and the one that was developed by the FDA back in the 50s and 60s is that there was no influence on the different lobbying groups. Our current food pyramid, unfortunately, was influenced by the dairy, grain industry, and a couple others as well too. And that basically determined what amount of servings you should have per day based on what they thought your intake should be after lobbying Congress. This one's a little bit different. This one specifically looks at foods that can be used to help make optimal choices and help out with inflammation on a daily basis. And as you can see on the bottom rungs, fruits and vegetables are the most prevalent, and that should be the biggest part of an anti-inflammatory diet. And from there, you get into things like pasta, whole grains, fish and seafood, healthy fats, all the way up to a glass of red wine or a healthy treat such as dark chocolate. All these things have anti-inflammatory effects, and they should be taken obviously in the amounts that are thought to be helpful for you. Everybody's different, so I can't say one thing's going to work for one person, but for a lot of patients, especially my headache patients or patients suffering from things like irritable bowel syndrome, it's a guess and check. And I have patients do these eliminations or additions very slowly and methodically. So as everybody heard, I'm a big exerciser. I believe in physical therapy as well too for my patients that have chronic ailments. It has definitely been shown that targeted exercise programs can enhance function and avoid deconditioning. The goals of these modalities are to target flexibility, muscle strength, as well as aerobic capacity. There is high quality evidence in the literature that supports the effectiveness of physical therapy with exercise and weight loss for patients with knee osteoarthritis in order to reduce pain and improve physical function. And I extrapolate that to every one of my patients. If you present with knee pain, hip pain, shoulder pain, a lot of the times it's because of either excess weight or overuse. And anything that can be done to help out with, controlling and correcting biomechanics, strengthening the muscles around that joint are all things that can produce great outcomes in terms of chronic pain management. The other one in this subheading is something called Tai Chi. It focuses on adaptive exercise. It also focuses on the mind-body interaction and also has an element of meditation, which is effective for treatment of things like osteoarthritis, low back pain, as well as fibromyalgia. The bottom line for any of this is that a body in motion stays in motion. And as the physician treating a patient with chronic issues or chronic pain issues that might hinder their physical capacity, what I tell them is this. I look at myself as the person to give you the tools to be able to make the long-term strengthening, anything to get back into motion. I am the vessel that tries to employ that for people. And a good chronic pain management doctor does the exact same thing for their patients as well too. Massage and acupuncture, how most of us would love to go and have one of these done right now. Unfortunately, COVID's a little precluding to that, but hopefully vaccines will be getting into arms soon and we can all keep our fingers crossed that the worst is behind us. So, massage and acupuncture, how does that play a role in chronic pain management? Well, in 2016, the University of California, Irvine's own Samueli Center for Integrative Wellness showed that massage therapy can be a significant and effective approach to manage various types of pain. It can provide improvement for pain, anxiety, as well as health-related quality of life issues. Acupuncture, on the other hand, may provide short-acting benefits for pain control. And right now, the best evidence for this is treating neck and low back pain, knee osteoarthritis, as well as migraine and tension headaches. Moreover, mindfulness, meditation, and talk therapy are all important ways of either causing distraction when a pain stimulus presents, or a way of minimizing the issues when people are actually having painful pain states. So non-directed relaxation techniques attempt to bring the focus off pain and break the cycle between pain as well as muscle tension. Techniques in this category include things like guided imagery, controlled breathing, as well as progressive muscle relaxation. Cognitive behavioral therapy, on the other hand, attempts to change attitudes and beliefs that underlie maladaptive emotional and behavioral responses to pain. Basically stated, if someone knows that they're going to have chronic knee pain every single time that they take a step, cognitive behavioral therapy tries to change those attitudes and hopefully decrease that maladaptive emotional thought to help people improve their functionality and hopefully improve their pain control. Moreover, mindfulness is an acceptance-based strategy that places emphasis on awareness, non-judgment, and meaning making in pain rather than a strategy to control, avoid, or fight pain. Awareness of the moment itself provides an opportunity to acknowledge and accept the difficult physical and emotional sensations that one may be experiencing. And when I bring these up to patients, usually what I'm doing is I'm bringing them up in conjunction with offering the patient a referral to psychology. I'm very fortunate that I have at my disposal a pain psychologist who only focuses on these issues with patients and has been an absolute blessing to my practice. As we move forward, any talk about interventional pain medicine would be amiss without a discussion about medication management for pain. Excuse me for 1 second. For many patients, pharmacologic interventions are the primary modality for treating pain in the geriatric population. There should be significant caution when using medications though. because the geriatric population presents a little bit of a more challenging and complex case because there is a high risk for adverse events associated with drug use in this population. And it has to do with a lot of different variables. It has to do with the polypharmacy that a lot of patients are on, the changes in metabolism, distribution, and elimination that occur with aging. So all these things need to be taken into account to give a patient a thoughtful prescription-based therapy. And that's kind of what my bottom bullet point talks about. All physicians must consider age-associated changes in drug metabolism, increased risk for adverse effects, and the likelihood of drug-drug interactions when prescribing these medications to a geriatric patient. So what are some of the medications that can be prescribed for chronic pain management? There are many different classifications of medications that can be used. The first ones that we usually think about in treating pain are things like non-steroidal anti-inflammatory drugs. So those are your ibuprofens of the world and Aleve. COX-2 inhibitors, which is something like a Celebrex that also helps out with the inflammatory-based pain, as well as things like acetaminophen or common over-the-counter Tylenol. From there, one can also consider topical analgesic medications, things like Salonpause and Icy Hot that you can get over the counter, all the way up to prescription strength 5% lidocaine patches, which are useful for the treatment of pain associated with either post-herpetic neuralgia or a shingles outbreak. From there, one can think about things like membrane stabilizers, and the classification for medications from that arena are things like gabapentin or Lyrica, which you see a lot of ads on TV for. Those are useful for the treatments of things like radicular pain, as well as fibromyalgia. Muscle relaxants are also a classification of medications that can be used for tension, muscle spasms, but again, these are things that should be avoided for the most part, unless they're absolutely necessary. Additionally, things like antidepressants, which would include your tricyclic-like antidepressants, things like Hamalor or amitriptyline, in addition to other medications such as selective serotonin and norepinephrine reuptake inhibitors, including medications like Cymbalta or duloxetine, are vitally important for the treatment of things associated with neuropathic-based pain. So many of you out there, unfortunately, may be suffering from diabetic peripheral neuropathy. These are two medications that are used on the front line in treatment for this disease to hopefully kind of tone down that burning sensation that people can get in their hands as well as in their feet. Finally, some prescriptions for opioid-based medications may be prescribed in the geriatric population. However, severe adverse events can occur with this medication administration and should be reserved for basically intractable either cancer-based pain or other, unfortunately, life-threatening issues. We're going to talk a little bit more about why that is here in a few minutes.
We have a question in the chat.
Okay, go ahead.
What are your favorite exercises for low back pain associated with osteoarthritis?
Great question. So technically the term your doctor may use is something called lumbar spondylosis or facet arthropathy. Basically what that is it's just an inflammation of the axial back resulting in just isolated axial back pain. And the same nomenclature can be used as well too in the neck region. For my patients that are suffering from lumbar spondylosis or isolated low back pain, obviously I would be amiss of saying, always talk to your doctor about treatment options. But for someone that has, let's say it's facet arthropathy or arthritis of the small joints of the articulating portions of the spine, my recommendation for that is something called core strengthening. The more that you can strengthen your core, the more that you can strengthen those muscles that stabilize the spine. So big muscles like your longissimus, your iliocostalis, your psoas, your hip flexors, anything that you can do to strengthen those, what you are in effect doing is you are basically offloading those little joints, you're stabilizing your spinal column, and hopefully augmenting pain relief that you would get from obviously activities of daily living or exercises that would normally cause pain. In specific, I'm looking at things like Pilates, core strengthening activities with planks, things that are obviously done to tolerance, and everybody's a little bit different. So I always advise people to do this with a personal trainer or a physical therapist. But all those things can be beneficial. Working on a recumbent bite in case you have any issues with stenosis of your spinal canal can be very beneficial too, because that can open up the aperture in the low back, take the pain off or take the pressure off the nerves in your back that might be causing leg pain. All these different things can be beneficial. Swimming, I love swimming. Swimming is almost a zero gravity, highly buoyant environment. And anywhere that you have any type of axial or even radicular pain associated with compression or arthritis, getting in and doing either swimming or aquatherapy is extremely beneficial to help out with these type of pain ailments. So those would probably be my, that's a very long-winded answer to a short question. So hopefully that helps out a little bit.
Okay, there's another question.
Yeah.
Sciatica.
Yeah.
I've been told there's not much to do other than lose weight. I've read that strengthening the abs does help. Are there any other approaches to be used?
So what I usually start out with this discussion is that sciatica is kind of a grab bag of a diagnosis that's used improperly. Let's start out with what true sciatica is and then go from there. Sciatica in kind of the lay literature is basically an impingement of a nerve resulting in pain that radiates down your leg. When I think about sciatica, I usually use a little bit of a different terminology. Basically what I tell people is they're suffering from something called radiculopathy, which is just a fancy term for a nerve somewhere in your spine is getting impinged before it comes out of the spinal canal. That results in basically leg pain, numbness or tingling, or weakness in a certain both sensory and motor region of the lower extremity or even up the upper extremity. A lot of the time sciatica gets misused for any type of leg-based pain, but that's what sciatica should only be referred to, is when there is a nerve involvement. So for a lot of people, they'll say, oh, my back and my posterior thigh hurts on the right side. That's not sciatica. That might actually be something like facet arthritis or arthritis of the little joints in the spine, or sacroiliac joint dysfunction, which is your biggest joint in your body, which is basically where your axial spine meets your pelvis. And that can cause pain down the back of the thigh as well too. True sciatica, again, is just entrapment of that nerve, resulting in pain that radiates basically past the knee. Doesn't always have to, but basically radiates past the knee with other neurological deficits. In terms of what you can do for management, again, it goes back to what is actually being treated. Is it just someone named it sciatica and it's not truly a nerve entrapment issue? I would say this, if someone just kind of brushed you off with that diagnosis and not really gave you a full explanation for what's going on, it is always within your power to find someone that's willing to sit down and explain things to you. And that's bar none what I tell people the first time that I meet them every single time, is that my job is to give you information to make a better informed decision about yourself in the healthcare system. And I think any good physician should be doing that as well too. Going back to, let's say it truly is a nerve entrapment issue in the low back region that's causing leg pain. Anything that you can do to strengthen your core, which does include abdominal exercises, is great. You're basically stabilizing the spinal column. But it always begs the question, is there another underlying issue that's causing these problems? If there is another underlying issue like dynamic instability of the spine that causes intermittent entrapment or pressure on those nerves, again, stabilizing the core would be wonderful. Other things that I tell people to do, if I've done an injection for someone that truly does have nerve-based pain emanating from the spine, I'm looking at core strengthening exercises. I'm looking at stretching, range of motion activities, getting them into aquatherapy. Anything that I can do to help strengthen the area where there's a debilitation or some type of, derangement is great. A lot of these times, unfortunately, it's discogenic problems. So it's a disc bulge or a disc herniation that's put pressure on that nerve. If that is the case, I'm still looking to do core strengthening activities, Pilates, yoga. Those are the things that I'm looking at. And again, it's all to function to strengthen the core as well as the hip flexors. It's kind of a side note, and again, a very long-winded answer to a short question. Studies have shown that 60% of back pain is actually mechanical, which means there may not be an underlying deficit in the spinal column or any of the nerves that are emanating from your back. And if that is the case, the best thing that can be done are things that help strengthen the core and help strengthen the hip flexors, just like the previous persons who just asked that question. Those are the things that'll really make a difference. And that's when I'm enacting a treatment plan or developing a treatment plan for a patient. That's what I'm telling people are the most important things to do. I can give you the injection or the epidural that's going to help out with the pain, but ultimately to make those big gains, the patient has to be willing to make the lifestyle changes that are important to them. I do remember a part of the question or part of the comment portion of the question being about weight loss. Weight loss can be really important because it will take off excess weight and pressure off of the spinal column, but that's only part and parcel of the true treatment plan. Again, a well-meaning and well-intentioned physician will sit down and lay out all those different things to help gain functional improvements as well as improvements in quality of life.
Yeah, we don't have any other questions right now.
Great. Thank you, Bill. So going back to medications and how do I determine which ones I want to employ and how, I usually go back to what we call the World Health Organization stepwise ladder for pain control. Now, this was originally developed to treat basically cancer-based pain, but when I teach residents, when I teach fellows, when I'm talking to patients, I usually employ this exact same modality as well too. And the central premise of this is that you want to start low and go slow. What does that mean? Let's say someone presents to my clinic with chronic knee pain. Basically, unless there's contraindications, I will think about using something like Tylenol, a topical nonsteroidal anti-inflammatory gel like Voltaren gel or diclofenac gel that's available now over the counter. I will consider using an oral nonsteroidal anti-inflammatory drug. I will probably get the patient into physical therapy, and I would consider doing some type of injection like a corticosteroid injection in the knee, a hyaluronic acid injection to help out with the viscosity and try to keep the areas where the bone is inflamed from rubbing on each other. Or consider a more invasive approach, which would include things like going after the nerves that innervate the knee, doing diagnostic blocks, and potentially denervating the knee by destroying the nerves in that region. So there's a whole host of different things that I would offer. Let's say some of those things don't help, including the medications. At that point in time, very rarely, and especially in the day of the opioid epidemic, do I ever consider using an opioid-based medication. To be 100% honest, basically I go around the country talking to people about how we shouldn't be using opioid-based medications to treat musculoskeletal pain. In my opinion, these should be used for patients that have exhausted all other modalities. It seems to be the only thing that's helping out with quality of life and pain control, and that there has been a very long discussion about the risks, benefits, and alternatives of this type of modality. At that point in time, if things still aren't beneficial or helping the patient, and we've exhausted, again, all the different modalities, adjuncts that we can use, there is always consideration for a strong opioid. Those would be things like morphine, Norco, Percocet, which is oxycodone, and Tylenol. But again, risks, benefits, and alternatives have to be described or discussed. And again, for most patients, you're now looking at cancer-based pain, things that are appropriate in my mind to use opioids for. Every patient, every physician is going to have a little bit of a different outlook on this, but I've unfortunately seen the ill effects of high-dose opioid as well as addiction issues, and I try to steer patients away from it as much as possible. So, as I had kind of said, very rarely do we as pain management physicians continue or start opioid medications because of the possible complications that these medications potentially present, which would include addiction as well as abuse. As you all know, we're not only living through a pandemic right now associated with COVID-19, but we're also in the midst of an epidemic, and that epidemic is basically the opioid epidemic. From a historical standpoint, this opioid epidemic evolved due to a rapid increase in the use of prescription as well as non-prescription opioid drugs beginning in the late 1990s. At this point in time, I'm sorry about that. At this point in time, the American Pain Society in the late 1990s aggressively pushed pain as the fifth vital sign concept with the goal of raising awareness to patients that pain was being undiagnosed and untreated. Half a decade later, in the late 1990s, the Joint Commission jumped on this train and emphasized that pain needed to be regularly assessed in all patients. At the same time, pain medications were being promoted to treat these patients, and unfortunately, opportunistically, drug manufacturers in the early 2000s funded publications to encourage the expanded use of opioids for pain control. Since that time, unfortunately, drug overdoses have become the leading cause of death in Americans under 50, with 2/3 of these deaths from opioid-based overdoses. And what I put in front of you is basically a schematic showing that among the more than 64,000 drug overdose deaths estimated in 2016, the sharpest increase occurred among deaths related to fentanyl and fentanyl analogs, which of this group, there was more than 20,000 opioid-based overdoses. What's really concerning is that now, flash forward, 5 years later, if we were looking at under 50 years of age as the number one, as the population in which this was causing the biggest issues, that population is aging too. So now we're gone from 50-year-olds to almost 60-year-olds using these medications on a regular basis. I, again, unfortunately see a lot of patients in my clinic that, unfortunately were started on opioid-based medications during the opioid heyday or prescribing heyday, that now are being cut off by their pain management physicians for a myriad of reasons. And I see what the devastation can cause by iatrogenic addiction, which is a patient came in for knee pain, their doctor started them on Percocet, and all of a sudden they've been on it for 20 years. I have the hard talks with people. I usually tell people that this is an issue. It's a health and safety issue. Obviously, you've been on it for a long period of time, but a lot of the times I look at myself as the conduit to get people the treatment that they actually need, which is to get referred to an addiction specialist, to work on the areas of weaning these medications, getting patients on an appropriate regimen, as well as treating their pain with non-pharmacological approaches. So it's really sobering. I mean, I understand, obviously, we're all concerned about the deaths associated with COVID, and especially in the geriatric patient population. It should be a extreme universal care at this point in time, especially with being able to get vaccinations into bodies. But this is still a problem. And in fact, the actual pandemic has accelerated what we thought we were making good progress with the opioid epidemic. So it's food for thought. If anybody that needs help, there are resources available, and I'd be more than happy to help point them in the right direction. So the fun part of my job, interventions for pain management. There are many different types of interventions that exist for the treatment of pain. For a lot of my geriatric patients, a lot of these things center around joint injections. So knees, hips, shoulders, things that I can do to try to temporarily alleviate pain, or hopefully in the long term alleviate pain as well too. Nerve blocks are a staple of my practice as well too. I can target nerves that both innervate joints as well as nerves that innervate different portions of the body. Take, for instance, something like the nerves that innervate the shoulder. Again, another nerve that innervates a joint, but may not have complete motor function, might have more of like a sensory function to it. Things that I can do to help out with chronic pain, any type of injection that's available and I think is safe and warranted, I will offer it to them. Epidural steroid injections, it's a big one for people that present with any type of radicular pain or radiculopathy, that nerve entrapment issue, either in the neck that radiates to the arm or in the back that radiates to the legs. Epidural injections can be very effective for these patients. I do a lot of Botox specifically for migraine headache. There is a protocol that's been validated and scientifically proven called the Preempt protocol that has been an absolute game changer in the treatment of migraine headache for a lot of my patients. For patients that present with things like myofascial pain or muscle tension and tightness, achy, dull, cramping feeling that's persistent, things like trigger point injections, which in my opinion is a little bit of Eastern medicine meeting Western medicine. A little bit of dry needling with the addition of a local anesthetic can be beneficial to help improve blood supply, oxygenation, and get waste product elimination out of those muscles where the tension is. Nerve ablations, I've talked a little bit about that, whether it's a hip, knee, joint, or other area of the body. All these things can be targeted for potentially destruction, especially if they are sensory-only nerves. And then the final one, spinal cord stimulators and pain pumps. Spinal cord stimulators, in my opinion, are usually used for patients that have had some type of failed back surgical syndrome, or patients that have things like complex regional pain syndrome of an extremity. Pain pumps, on the other hand, are usually used in my practice a lot for spasticity with things like baclofen, or cancer patients that can no longer take oral-based medications, or they're having significant side effects to oral-based medications. So, in conclusion, pain in and of itself is a complex biological process. There are many pharmacologic and non-pharmacologic treatment modalities that exist to treat pain. A good chronic pain treatment plan should be multidisciplinary in approach, and the true treatment for pain is obviously prevention. Again, happy to share my references with you, and if you have any questions, I'd be more than happy to open the floor.
Yes, we have a question from Pete.
Okay.
Two questions. One for your steroid injection. What are the health effect risks of steroid, and how often should you get them?
Great question. So what I use is an equivalence dosing on a yearly basis. So what studies have shown is that about 3 milligrams per kilogram of triamcinolone equivalents is what should be the uppermost limit for a patient on a yearly basis to prevent suppression of the hypothalamic pituitary adrenal axis. With long-term steroid use or too much steroid use, you can get into a myriad of different problems. You can get into bone demineralization, decrease in sex drive, changes in fat regulation and deposition. You can also get changes in glucose metabolism issues. You can also get change in blood pressure regulation. So for all of these different things, I'm really conscientious about how often I inject steroid into patients and basically into who I inject steroids into. If someone's on chronic steroid therapy for, let's say, COPD, whether it's an inhaled corticosteroid or an oral corticosteroid, or some other type of respiratory problem, I really have a risk of benefit analysis discussion with the patient to see if there is, if the injection with steroid is warranted, or if there is another injection that we can perform that might help them out more without exposing them to the risk of steroid. So for all those different reasons, yes, there can be some really big long-term effects associated with steroid, and everybody should have a single discussion about what may be beneficial and what may cause harm before proceeding with their doctor.
Second question was, you mentioned ablation.
Yep.
Frequency question on that. My particular question had to do with radio frequency, but what is the frequency issue there? And I guess that's more effectiveness than maybe it is risk. But
radio frequency, I can't remember the exact frequency that we use. Let me talk to you about the risks associated with it, though. No long-term risks have been shown to be associated with the 90 seconds in which the radio frequency is being used to basically heat the surrounding tissue and coagulate the nerve. The big risks for any of these procedures comes with the actual setup of the procedure. So let's say I'm going after the nerve in your back that innervates the joint that has arthritis. The biggest concerns that I have would be potentially getting too close to the motor nerve, which is very close to that, what we call the neural foramen. So the medial branch nerve is what innervates the joint. The motor nerve and sensory nerve enters out of that same foramen. It's a lot bigger and it's a little bit more anterior. So for things like this, we would do sensory and motor testing to assure that we are actually on the nerve that we want to destroy, and motor testing to make sure that there are no off-target lesions that are created from the actual radio frequency. And pain practitioners know the diameter of the lesion that's being created. They know what type of cannula causes what type of burn or lesion. So a lot of the times it's a very safe procedure, but obviously there's certain testing protocols as well as imaging approaches that have to be used to make sure things are done safely.
thank you.
No problem. Thank you.
Paul? You're muted, Paul.
I wanted to ask you about rebound headaches.
Yeah.
If one goes several days and is not getting relief from, say, Excedrin or other over-the-counter medications, and the headache persists, is it possible it's a rebound headache? And if so, what might one do for that?
Great question, Paul. So first thing I would always tell people is that headaches are nothing to be trivialized, and they can be also life-threatening. So the first thing to do is always talk to your primary care doctor. A lot of the patients that I see for headaches, I also work in conjunction with the neurology team to make sure that there's no intracerebral pathology, no vascular pathology. And assuming that is the case, patient presents to me and let's say they've been using a preventative medication like, let's say it's a migraine with aura. They've been on something like propranolol in the past. They've been using Topamax. They have been on a non-steroidal anti-inflammatory like a Aleve or Excedrin migraine. And they've been, decently controlled, but what they'll notice is that when they get a bad headache, they pop one of those Excedrin migraines. They basically go down, lay down, rest, and feel better when they wake up. That Excedrin migraine, when it's used too much and too frequently, will basically cause that rebound headache in the ensuing couple days. What I always tell people, and when I usually see the rebound headache, is when they've been using multiple medications and then some form of an attempted abortive like caffeine, a non-steroidal, Tylenol, Fioricet, something like that. Fioricet is also a medication that has a barbiturate and trained with or encased in it as well too. What I tell people is that just like anything else in your body, if you've built up some type of tolerance to it and your body has a dependence on it, it's going to take a little while for it to not have that tolerance or have that dependence on it anymore. And those medications need to be titrated off slowly over time. And that is the way that you will basically beat any type of rebound headache, is taking that abortive and decreasing its use and decreasing its dose over time. It's going to be slow and steady, but again, slow and steady usually wins the race.
Okay, thank you.
No problem. Thank you.
Okay, we have another question in the chat.
Great.
What are your criteria for doing a sacroiliac joint injection?
Great.
Is this treatment effective, and how long does the pain relief last?
So I'll always tell everybody responds differently to injections. With that said, sacroiliac joint pain, SI joint is basically the biggest joint in your body. Surface-wise, it's about the size of my palm. It's about 17 square centimeters in surface area, of which about 2.5 cubic centimeters are actually fluid-filled or a synovial-based joint. SI joint pain basically comes from the articulation of that joint. Let's say this is your SI joint. This is the pelvis. Basically, there should only be about 2 to 3 degrees of freedom in that joint space itself. What happens over time is that people develop back and hip pain. They basically change their biomechanics and they end up putting a lot of torque force into that joint. Or alternatively, the ligaments loosen over time, resulting in articulation that results in inflammation, which ultimately causes pain. The criterion for which we use is a bunch of different physical exam maneuvers in the clinic, plus minus any type of radiologic imaging. If I'm doing radiographs or x-rays, I want to look for degeneration or inflammation along the SI joint. On physical exam, I'm doing different maneuvers, different provocative maneuvers that basically put a shear force into the joint that can reproduce pain. By what the insurance companies mandate, or the Noridian mandate here in Southern California, we have to have at least 3 positive provocative maneuvers. And those can include things like flexion, abduction, external rotation of the SI joint, Yeoman's or Stork's test, SI joint compression, or something called Gainsland's test. Assuming that you met the criteria for an SI joint, I would consider doing an SI joint injection. On average, about 60 to 80% of my patients receive about 60 to 80% pain relief after the injection. There's usually 1 of 3 ways it can go. Patients can either get great initial analgesic relief or diagnostic relief from the local anesthetic, and good long-term relief from the steroid lasting at least 3 months. Patients can get good diagnostic relief, which means the local anesthetic alleviates their symptoms for a period of 6 to 8 hours, but they get no relief or long-term relief from the steroid. or you can get no diagnostic relief and no basic long-term therapeutic relief from the steroid, meaning that it probably wasn't the SI joint causing the problems. Based on the response, not only can you do the injection with steroid in that SI joint, but there are certain pain practitioners, and myself included, who actually can offer what we call an SI joint ablation, which is where we go after the posterior nerves that innervate the joint and try to get at least 6 months worth of good pain relief. Again, everybody's different. I can't tell you what modality may work for you individually, but it's a good discussion to have with your physician.
Okay. Where can I see more details about the elimination diet you suggest?
Great question. So the elimination was by Dr. Wheel. If anybody has visited the restaurant called True Foods, that is actually his restaurant. I know he's written a bunch of books as well too. So what I would do is I'm going to actually scooch back in my slides right now so everybody can see that pyramid. Oh, there we go. This pyramid was actually in Headache Magazine in March of 2013. And Dr. Wheel's name is W-E-I-L. A quick Google search will bring up a lot of the information specifically pertaining to what we call IgG, which is what he is basically trying to eliminate, or the molecule in your body that can potentially cause the inflammatory cascade. And that anti-inflammatory food pyramid I know is contained in most of his books, as well as on a lot of different websites on the internet.
Okay, does anyone else have any other questions tonight? You could raise your hand or type them in the chat. Okay, I'm not seeing any other questions right now. Oops, yes, we do. Maria, did you have a question? No, she put her hand down.
Okay. Just trying to get that last one in on the wire.
Yes. Any other questions? Okay.
Can you hear me?
Yes.
Yes, again.
Okay. Doctor, I've had a laminectomy in 2014 for spinal stenosis.
Okay.
I got relief for about a year, and then the burning pain and the numbness never really went away. That's just always there. I've just learned to live with it. I cannot take NSAIDs because they've impacted my kidneys. I don't tolerate opioids at all, and I don't think I need them. I get by with gabapentin for the burning pain, but the backaches are just constant and now spreading to my other leg, which really scares me.
Okay.
They told me I have spondylolisthesis.
Okay.
And so far, the only thing that's been offered to me is a spinal fusion, which I do not want to do.
Okay.
So I kind of have to learn to live with this since I don't tolerate pain meds very well.
To a point, obviously, I will say this and preface this with I can't give any type of medical expertise or information or insight into your clinical case as a physician or as your treating physician right now. But spondylolisthesis is basically the movement of the vertebral bodies over one another. It can cause what we call dynamic instability. And depending on what the degree of instability is and how it's actually affecting both the nerves that innervate your leg as well as the nerves that innervate your bowel and bladder area, that can be actually an indication for surgery. What I would say is this: if you can find a pain management physician that you trust and are wanting to work with, what you can do is you can always try core strengthening activities, focus on things like possibly an epidural steroid injection, as well as have that professional review the images, make sure that there is no current life-threatening or what we call red flag issues that may cause permanent neurological damage. And then at that point in time, discuss a treatment plan. Most surgeons won't recommend a spinal fusion unless they think it's absolutely necessary. And it's always your prerogative too to make sure that you have at least 2, if not 3, opinions on your situation. Don't rush into surgery, as you shouldn't. You should make a thoughtful and thought-felt approach to it, and just discuss it with as many people as possible before you even go in that direction.
Okay, I'll do that.
Good.
Any other questions tonight?
Thank you.
You're welcome.
Okay, then we want to thank you, Dr. Shibish, for talking with us tonight. I'm sure there's lots of people that dialed in tonight to listen to this type of topic. So thank you for the information that you gave us.
You're welcome. Thank you for having me tonight. I truly appreciate it. And I hope everyone stays safe and stays healthy.
Okay, thank you. So next week, our lecture will be on an update on vaccines for older adults, and specifically flu shots, pneumonia, measles, DPT, shingles, and coronavirus. So we'll see you next Wednesday at 9 a.m. Also this Saturday, the Transitions in Retirement series will be presenting financial wellness during tough times, and that'll be at 9:30 on Saturday morning. So thank you all for joining today, and we'll see you next week.